Good afternoon or good day, everybody. Welcome to our Muscle Health Research Center seminar this afternoon. I was going to say, I'm saying this afternoon, but for our speaker, it's just around lunchtime in British Columbia. I'm delighted to introduce Dr. Bill Sheel. Bill is at Department of Kinesiology at University of British Columbia in Vancouver. He's originally from the east side of the country, did his bachelor's degree at UNB in Fredericton in kinesiology, then went to Vancouver and did his master's and PhD at UBC. Then he did a postdoc with at the University of Wisconsin with a very well-known respiratory physiologist, Jerry Dempsey, who is very prominent in the field, and it must have been excellent training for Bill. He also did a sabbatical at Copenhagen with Rob Bushell at one point. So he's traveled. He was telling me he's traveled to various parts of the world to study athletes. And I'm delighted that we're talking about the lung for a change. We haven't really had anybody speak about lung function and respiratory muscles. And so that'll be great to hear. The title of Bill's talk is Competition for Blood Flow Distribution Between Respiratory and Locomotory Muscles, Implications for Muscle Fatigue. So what I'd like to do now is ask Bill to turn on his camera and unmute himself and share the screen. And we'll get started. Bill, take it away.
Great. You can hear me?
Yep, gotcha.
Great. Terrific. Well, thanks very much, David, for the introduction and invitation. And also thank you very much to Heather for putting my name forward for this. And it's a pleasure for me to share with you today some of our ideas about respiratory muscle. So just by way of introduction, I thought what I'd do, given what David just said about the lung not being a primary focus of the group, is go through a handful of fundamentals and a couple of measurement techniques, which will be important as we get towards the end of the talk. So shown here is the response to exercise from rest to maximum. It's a unitless y-axis. And you can see, of course, ventilation goes up, cardiac output goes up. You can argue about whether it plateaus or not. O2 uptake increases. And then shown in the middle are the different organ systems related to that. So the lung, airways, chest wall, respiratory musculature, generating changes in frequency, tidal volume, etc. Cardiovascular variables shown there from rest to maximum in the untrained individual, as well as what happens at the level of the tissue. But what I would draw your attention to is that the arterial blood gases, for example, arterial partial pressure of oxygen in a healthy person is maintained, even in the face of maximal exercise and a several-fold increase in many physiological variables, implying that the respiratory system does its job. But what I'm interested in, and we'll talk about today, is the musculature that generates the appropriate ventilation to maintain blood gas homeostasis. So the respiratory system faces a number of challenges. I won't go through all of them, but one is that the gas transport needs of both respiratory and locomotor muscles must be considered. So we need to think of that in terms of both sets of muscles. If you think of exercise being performed maximally, there's a finite amount of cardiac output for distribution. How do we prioritize where that blood should go, and does that have any implications? So by way of review, go through some of the respiratory musculature. I won't read these all to you, but they can be divided broadly, given this is a muscle symposium, into those that generate negative introthoracic pressure. So that is bringing air into the airways and lungs. And the primary muscle shown there is the diaphragm, of course, which is innervated by the phrenic nerves. The other muscle which will become relevant today is the sternocleidomastoid, which lifts the clavicle up and out to help produce that negative pressure. But also we need to consider the expiratory muscles, those that generate intra-abdominal pressure generation that's positive, so you can expel air. Of note is that a number of these muscles not only have respiratory function, but they also have postural and locomotion roles. So it's a nice summary in the last year or two describing the respiratory musculature. And I think sometimes this is underappreciated, that there's 63 muscles or so with a documented role in breathing. So I've shown the ones here that generate intrathoracic pressure changes, but there's a number of upper airway musculature, and in particular around the throat and the glottis, which are very important. And so fractionally speaking, that's about 20% of human skeletal muscles have some function related to breathing. So a very important grouping of musculature or classification. So what are the demands placed on the respiratory muscles with exercise? I've given you some of the broad brushstrokes, but what will we talk about today? What's the mechanical work associated with breathing and exercise? How much oxygen is taken up by the respiratory musculature when performing exercise, and high levels of ventilation are incurred? Pardon me. Then we'll come to the question, does the diaphragm, as the primary muscle of inspiration, does that fatigue with heavy exercise? And then what I'd like to do is end with some of the newer data that we've put together in the last year or two, addressing the following questions. What are the respiratory muscle blood flow requirements? And does that influence locomotor blood flow or cardiac output distribution? And if it does, what are the mechanisms? How does that occur? So just to orient everyone, in terms of how do you measure work in the respiratory musculature? Well, it's a little different than some of the other muscles that I suspect many of you study. We use pressure as a proxy for this, as a proxy for force. So on the left-hand side is just the cartoon from John West's pulmonary textbook. At the end of a normal breath, where no air is flowing in or out of the lung, and the pressure inside the thorax is equal, or inside the lung is equal to the pressure outside of the lung, so 0. But the pleural pressure is about -5 centimeters of water. And so that's what's keeping the lung from collapsing and the chest wall from springing out, is what's happening in the pleural space. Shown on the right-hand side is what happens if you poke a hole into someone and you get a pneumothorax. Well, the lung tends to collapse and the chest wall tends to spring out. Why is that relevant? Well, it becomes relevant in how we try to measure the mechanical work of breathing. And so here is a cartoon of a subject, and you can see that this catheter system, so PES, esophageal pressure, PGA, gastric pressure, and in this instance, there's a diaphragm EMG catheter system in the middle. We won't worry about that for today. But the difference between those is the pressure across the diaphragm. Right? So you can measure diaphragmatic pressure under conditions of exercise. And why do we do this in terms of esophageal pressure? Well, shown on the right-hand side is a CT scan, and you can see the pleural cavity lining the thorax there. And then you can see its very close proximity to the esophagus, which is a very flaccid structure. So when you take a breath in, you generate negative intrathoracic pressure, and it is transmitted to the balloon, which is shown on the left-hand side, and that's connected to a pressure transducer outside of the subject. So it looks kind of like this. People often wonder what it looks like, and so this is just a video of a volunteer graduate student, as they say. And so what's happening here is she's inserting the balloon catheter system. There's a guide wire in it. It's fairly stiff. He's had some viscous lidocaine applied to kind of prevent as much of the gagging reflex as you can. We advance it down until it's about in the lower third of the esophagus. And you can see here he's sipping water to prevent the gag reflex. And we get it in. She pulls out the guide wire. There's a bit of a response here. No, that's okay. And then there's a bit of technical gymnastics that goes with that to place it correctly, but you can perform exercise. So that becomes important as we go through some of the remaining slides. So if you have that esophageal balloon pressure measurement, you can integrate the area, a pressure volume loop, right? And then from that, that's what we use to calculate the work or power of breathing, shown here on the y-axis in joules per minute as a function of minute ventilation. And for the purpose of today, we'll ignore the fact that men and women appear different. Maybe during question period, I could answer some of those if time permits. But it's a curvilinear relationship. We're certainly not the first group to show this. That's been going around for 100 years or so. But what is a little bit new, and I'll come back to this in the last couple of slides, is that you can take that work of breathing value and you can model it to partition it out to calculate the resistive work of breathing. So the work done in overcoming the resistance to turbulent flow. So you maybe think, some people I think on this call are cardiovascular folks. So that would relate to the diameter of the vessel, in our case, the airway. So radius to the fourth power becomes very important if you're thinking of Puiset's equation. And then the other term here is viscoelastic component of the work of breathing, and that's the work done to overcome the resistance offered by various tissues in the thorax. So we'll come back to the resistive component at the end. But nonetheless, high work of breathing with exercise. Okay, so following that, how much does it cost to breathe in terms of oxygen consumed? And so this is a little bit of a difficult question to address in a human, but the way that we did this, we had subjects come to the lab. They were instrumented with those balloons that I mentioned. They performed an incremental exercise test to exhaustion. We recorded pressure, volume, flow, timing, pattern of breathing. Then we brought them back to the lab on a separate day and we instrumented them again. And then we had a preset scenario, which you can see on the left-hand side, that the subjects would look at, which was a flow and volume loop and a pressure and volume loop, and they had to mimic those. And so they're replicating what happens with exercise in the absence of exercise. So if you know what VO2 is with exercise, and now you can measure it here, you can calculate what the oxygen consumed by the respiratory musculature is to perform those levels of ventilation. And so it looks a bit like this. This is esophageal pressure as a function of volume, and this is with exercise on the top. And so that's a pressure volume loop at 45 to 100% of maximal exercise. You can appreciate that the area of that pressure volume loop is increasing, meaning that the work of breathing is increasing as a function of exercise intensity. So that's not new. But what we did is we had them replicate that, and this was hard. This is kind of rubbing your head and patting your tummy at the same time, and some people frankly weren't very good at it. So we wound up throwing out a lot of data, but when we got it to work well, it looked like this, and you can appreciate that qualitatively we're able to replicate those values. And so the ventilations are the same, and the mechanical work of breathing is the same between the conditions, but what is the oxygen consumed by the muscles of breathing? And that's shown here. The y-axis is VO2 RM, or respiratory muscles, as a function of increasing ventilation or exercise intensity. Each one of those dots represents a single subject. We usually did 3 to 5 trials per, so there's close to 600 trials to do this study. Most of the subjects didn't like us by the end, but we were able to soldier on. And so what you can see here, and again, we'll come back to men and women if time permits later, but the amount of oxygen consumed by the muscles of breathing is 400 mils. Well, that's a lot, right? If you think of someone's VO2 of maximum is 3 liters a minute in some of these people, that's a significant fraction of VO2 being diverted to the muscles of breathing. And so by our calculations, these are consistent with what some other people show. About 9 to 15% of whole body VO2 is directed to the muscles of breathing. So the muscles of breathing are commanding a significant fraction of oxygen during exercise. Okay, so the next question, and then we'll move on to some of the newer data we have, is does the diaphragm fatigue with exercise? And I wondered if this might be of interest to some of the group on this call. So how do you do that? Well, we instrument the subjects with those balloon catheters again. So one in the esophagus, one in the stomach. Hopefully you can see that, and those are connected to a pressure transducer. And then we need to stimulate the muscle to contract. And in this case, we're interested in the primary muscle of breathing, which is the diaphragm. So we need to stimulate the phrenic nerves, and we do that with a magnetic coil. And it's delivered at 1 hertz. There are other electrical ways of doing this, but in our hands, we've been using cervical stimulation as of late. And so it looks a bit like this, where the subject's breathing in and out. And then we deliver the one stimulus, and you get a change in PDI, or the pressure generating capacity of the diaphragm. And so that's your measure of strength or pressure generating capacity. So you measure that before and you measure it afterwards. And if you have a reduction in that PDI twitch, then you can be somewhat confident, provided you're stimulating the same way both times, that there's some degree of fatigue. And of course, other people have shown this. We're not the first, but this is to show you what that looks like, and also with a little bit with respect to recovery. And so shown is PDI twitch on the first y-axis. The right-hand axis is the right hemidiaphragm EMG. So we want to measure the M wave in this instance, just to make sure that's relatively the same under both conditions. That gives us some confidence that we're stimulating the muscle the same way. And so the PDI twitch, the largest spike at the top, that is the baseline value. And then in this case, we had subjects perform exercise to, I believe they're at 85 to 95% of maximum power output. They cycle to the point of exhaustion, and you can see that 5 minutes after that bout of exercise, the pressure generating capacity of the diaphragm is significantly reduced. And in this study, we documented the time course of recovery. And it does come back to normal, but it's certainly not an instant process. Okay, so let's take one step back. If we think of what I've told you this far under conditions of exercise, well, there are many different things going on with exercise, as you know. Let's remove many of those and isolate the work of breathing in the absence of exercise. Let's make it hard to breathe. So that, to address the question, do high levels of respiratory muscle work influence the regulation of blood flow or vascular control? And so what's shown here is the technique called microneurography, where you can impale a superficial nerve with a tungsten electrode. It's very fine, small diameter, and you can record vasomotor outflow to the muscle, and that's shown here. The top panel is arterial pressure, beat by beat. The middle panel is muscle sympathetic nerve activity, and the bottom panel is mouth pressure. And so it's a bit of a strange paradigm, but bear with me. So what we wanted to do here was to fatigue the diaphragm. And so how can you do that in the absence of exercise? Well, we imposed a duty cycle. So 7/10 of the time was spent on inspiration, and they were inspiring at 60% of maximal inspiratory pressure. The analogous scenario would be someone doing rhythmic hand grip exercise. Squeeze, relax. Squeeze for a prolonged period of time, relax, where you're making the muscle presumably relatively ischemic. And this protocol we developed is based on some nice dog data out of Montreal in the 80s, François Belmar and Alex Gracino. And so when you expose the muscle to that increasing pressure and prolonged duty cycle, what do you see? You see this time-dependent rise in both amplitude and frequency of sympathetic nerve activity, and you see a rise in blood pressure as well, suggesting that, yes, high levels of respiratory muscle work do play a role in how it is cardiovascular control occurs. So this is a slide, it's a summary slide, and it summarizes a number of years of work, some of which I was involved with, some of it I was not. So let's orient to the panel on the left. That's esophageal pressure, which we went through earlier. And then the bottom panel B is diaphragmatic pressure. So the pressure generating at the esophagus. So that's all of the inspiratory muscles. And then the bottom panel is the pressure generated with the diaphragm, the primary muscle of breathing. And what you're seeing is that's averaged over a period of time, a breath. So that's a single breath. So it's multiple breaths, signal averaged. In the control condition, okay, negative esophageal pressure, diaphragmatic pressure is increasing. Okay, so you're generating flow with your diaphragm. Now, what's unique about this is the other condition, PAV. So it's a proportional assist ventilator. It's slightly different than what you'd see in an ICU. I guess it's timely to talk about that. But you can unload someone's breathing while they're exercising at maximum. And so it's actually quite euphoric. If you ever are out here in Vancouver, we can let you have a try, but you don't know how much it costs to breathe until you've had it removed. It's quite, it's quite something. So what are the effects of this? So again, I'm summarizing several studies here. Excuse me. So if you reduce the diaphragmatic work with exercise, as shown on the left-hand side, it prevents diaphragm fatigue. We know that you can reduce sympathetic tone and change vascular conductance and blood flow. I'm going to show that in a moment. It attenuates locomotor muscle fatigue. So people perform the same amount of exercise, they actually develop less peripheral fatigue at the level of the quadricep at least. You change the sensations of respiratory discomfort or limb discomfort as well, and people can exercise longer. So it's an interesting tool. I'm happy to talk more during question period if you'd like. But this is the effect of blood flow, and this is where I want to change directions and talk a little bit about some new things we've been doing. So this is an older slide. This is from Dr. Dempsey's lab, redrawn from 1997. And what you see is work of breathing on the x-axis, and that's been normalized. So control, 2% control, pardon me, and leg blood flow. And that's been measured using thermodilution across the femoral vein and artery. Okay, so if you use this proportional assist ventilator and you reduce the work of breathing, you have a increase in leg blood flow. Conversely, if you make it harder to breathe and you put a resistor into the circuit, so you increase the work of breathing, you have a reduction in leg blood flow, suggesting that there's some sort of competitive relationship for cardiac output. So if the work of breathing is decreased with the ventilator and leg blood flow is increased, where's that extra blood flow coming from? And how is it happening? So to this point, we've assumed that it was respiratory muscle blood flow, but it didn't need to be. What are the respiratory influences on sympathetic control of blood flow? I showed you the other example under very narrow lab-based conditions, isolated respiratory work. Is that present during conditions of dynamic exercise? So to address these questions, I'll go through the next couple of studies. This is the work of Paolo Dominelli, who was a graduate student in the lab, who's now faculty at Waterloo, and I want to make sure I give him all the credit that's due. This is his work. And so this is the control condition. And here you see esophageal pressure. So negative on inspiration, positive on expiration. And in this case, we had EMG on the sternocleidomastoid, which I talked about earlier. And you can see that it's active, it's bursting, just qualitatively that's there. We see minute ventilation and work of breathing values for those handful of breaths. Okay, let's put a resistor into the circuit. I have to say that isn't a lot of fun to do, but nonetheless, it's a good experimental tool. So we see a huge increase in work of breathing. You can appreciate the swings in esophageal pressure are much higher. And you can see that the EMG activity of that accessory muscle, the sternocleidomastoid, is also increased. And then if we apply the ventilator, a different trial, and we are able to reduce the intrathoracic pressure swings, and you can see work of breathing is almost down to nothing, it's 20% of control, and the sternocleidomastoid is quiescent. So we're able to successfully manipulate what we want to manipulate with this ventilator that we built. So to address the question of blood flow, there's a technique shown here where we're able to assess that in multiple vascular beds. It's called indocyanine green, and hopefully you can see that. That's shown here in the arm. We're infusing indocyanine green into the venous circulation. Okay, and so we do that at discrete points during the experiment, and the dye gets into the circulation and it appears in different vascular beds. And what we've done is we've placed near infrared spectroscopy. We're able to adjust it such that it picks up green. And so the rate of influx of that dye is proportional to blood flow. And so what's unique about this is that we, in this case, you can see it's placed on his leg, but we also have it placed on the sternocleidomastoid, which is on the other side. You can't see that, under three conditions: control, resistors, make it harder to breathe, and the ventilator, which you can't see, but he's connected to, where we make it easier to breathe. So what you see here is similar to what was in Dr. Dempsey's slides, where you have work of breathing percentage as a percentage of control for sternocleidomastoid, vastus lateralis, and vastus medialis. The technique's not perfect, I will confess that, but directionally it's doing what it should do. When we reduce the work of breathing, we reduce blood flow to the respiratory muscles. So that's a unique finding to this study, that we're able to document a reduction in blood flow. Conversely, when you make the work of breathing harder, there is an increase in sternocleidomastoid blood flow. And I think there's some students on the Zoom call, but these are the two data points that kind of keep you awake at night. But those are real. Those relate to directly to the EMG recording on the other side of the person. And so I mention this to emphasize that breathing is a learned activity, and people are going to breathe differently when you start mucking around by either unloading or loading. Particularly with loading, it's a very disquieting sensation to feel as though you're having to work that much harder to get oxygen into you. So to interpret this, manipulating the work of breathing results in directionally opposite changes in blood flow between respiratory and locomotor muscle. And it supports the notion, and admittedly my bias, of a competitive relationship between active vascular beds with exercise. So to address the next question, what are the respiratory influences on sympathetic outflow with dynamic exercise? How is this occurring? So to do this, we collaborated with my friend Keisho Katayama, who's from Japan. And he's a unique person, that he can record muscle sympathetic nerve activity from the upper limb. In our case, we use the median nerve during dynamic exercise, and that's shown here. So this is under conditions of, quote, real exercise or larger muscle mass exercise, rather than just hand grip or isolated diaphragmatic work. So in this study, what we did is we used the ventilator, which you can see here. And then we had a number of different trials. For those of you that have participated in these kinds of studies, you'll know that you wind up throwing out more data than you keep, and it's a very finicky technique. So there were some issues with the design, so I'll draw your attention to this. So what we did was we had them perform 40, 60, and 80% of maximum. It wasn't possible to randomize this. The priority was to keep that nerve signal stable, and you can see that's unfortunately, that's me there on the bed, and my upper limb is stable, and we're recording from that. So what becomes relevant is the conditions from when the subject is on the PAV to immediately post-PAV. And it looks like this. So here's a condition of at 156 watts or so, mean arterial pressure, minute ventilation, work of breathing. We haven't talked about mouth pressure, but it'll become obvious as I click through the slides. Esophageal pressure we've talked about, and there's some basal firing, if you will. So you could count the bursts, or you could count, or you could measure the amplitude. In our case, we measured burst frequency. So then that's the control condition, or immediately post. When they're on the PAV, what do we see? So there's a positive mouth pressure, which confirms that our device is breathing for the subject or pushing air into them. The esophageal pressure swings are much less, and the work of breathing is almost half. And the number of bursts per minute is just visually lower. So the mean data looks like this. So this is muscle sympathetic nerve activity, burst frequency as a function of time, over a time trial. And so here's the condition where they're on the PAV. And again, what we were most interested in was what happens when you turn the PAV off and you come back to the normally occurring work of breathing. So this suggests to us that, yes, if you remove the work of breathing, that does have an effect on sympathetic activity, meaning that normally occurring work of breathing has an influence on vasomotor tone. And if we average that across all of the intensities, what's shown here is O2 consumption as in absolute terms, pardon me, as a function of muscle sympathetic nerve activity. The black line is the control condition. So there's this rise across intensity. And then the blue line is the trials that we used with the ventilator, and we were able to reduce that. So we're interpreting that the shaded gray area is reflective of the respiratory system's contribution to sympathetic vasomotor outflow during dynamic exercise. So in sum, lowering the normally occurring work of breathing during exercise reduces muscle sympathetic nerve activity. We think this means that this is evidence of a sympathetically mediated vasoconstrictor effect emanating from the muscles of respiration during exercise. Now, this is not our work, but it's been very important to our way of thinking and interpretation of what we see in the human. And so this is from Harold Laughlin's group in Missouri, and this is from a rat model where they're looking at norepinephrine-induced vasoconstrictor responses in different arterioles. So they compared the diaphragm versus locomotor muscle, and what they term in this paper red gastroc and white gastroc. So the vessels are isolated, they're exposed to different concentrations of norepinephrine, and they're able to measure the diameter of the vessel in response to increasing dosage of this vasoconstrictor. And what you can see as you get towards the right-hand side of that slide is that the diaphragm responds differently than does the locomotor muscle, at least under the conditions of the rat, under a rat model, pardon me. So the maximal responses of the diaphragm arterioles are significantly less than that of those in locomotor muscle. So that might have some implications for how it is blood flow is perhaps preferentially distributed to different tissues. So this is a summary in the last year or two of part of the way we've been thinking about this. And so on the left-hand side is the pulmonary side of the equation, and then the right-hand side is the locomotor muscle side of the equation, and with a finite cardiac output to be distributed to different muscular beds. And so the way that we've been thinking about this is that high intensity contractions of both sets of muscles, whether they be respiratory or locomotor, cause an increase in group 3 and 4 afferent activity that project to the brain. And then the efferent signal is a sympathetically mediated vasoconstriction. Now, what we don't know, we know that that occurs or seems to occur based on what we've shown in the peripheral vasculature. Whether that occurs in the respiratory muscle, based on the Acker study, would suggest that maybe there's some preferential blood flow being redistributed to the diaphragm or other muscles of breathing at the expense of locomotor muscle. And so David mentioned that my postdoc mentor was Dr. Dempsey, and he, when I got my position, told me, when you get invited to give talks, don't always give the same talk. Make sure you leave with something new. What have you been working on it? And I'll try and bring this back to the first handful of slides to show you some of what we've been thinking about lately and how it might relate to the topic at hand. So what's new? This is what we've been doing lately, is trying to understand the relationship between respiratory muscle contraction during exercise and specific measures of airway anatomy. And so what this is a participant, me, in fact, it's what happens when you come up with ideas, you get to go first, with a bronchoscope. So we're down at a bronchoscopy suite, and these are our colleagues there, Dr. Lamb, who has a bronchoscope in me. I'm unconscious. And what happens is the bronchoscope is advanced, and then they open the biopsy port. And from that biopsy port, they insert a very small sheath, and so it protrudes, and you basically advance it until it wedges. And so when you do that, it looks a bit like what's on the top here. It's in a protective sheath, of course, but you can get some very detailed measures of airway anatomy. So it looks like this. Hopefully this works. So the probe is being pulled back at a fixed rate. It's spinning, it's emitting a light, and you can see the bifurcation of the airways there. Right? So if you can do that, and there is some work with the physicists to come up with this, but you can get at least an 7 to 8 centimeter pullback in the airways. And so now you can potentially create an index or airway model, right, of what the airways look like. And does airway geometry relate to how it is the muscles operate with exercise? So it looks a bit like this. This is the top. This, you can see this is the sheath of the probe. This is the airway wall. And there's some suggestion that these are, you're starting to get down towards the alveoli. So this is distal at the moment. And what happens is in the pullback, consider it like a paper towel roll, where you can split it down the middle and lay it flat, and you can look at each of the branch points. And it looks a bit like this as you pull the device back, or the probe back, and it's moving along. You can see it's hitting these branch points in the middle panel, and the vessels are getting larger. So we're able to quantify how much they change across a specific point of anatomy. And we can relate that back, hopefully, to what happens the level of the muscle. And so you can get these images and they look like this. And so you can go ahead and you can calculate the luminal area, which of course is going to dictate the properties of airflow, which of course is related to the contractions of the muscles themselves. So that's what we're working on next, trying to create a model that links airway anatomy in a kind of unique way to the contraction of the respiratory muscles. So we're currently doing this in health, but it certainly would be interesting to look at with patients with lung disease who may have differences in airway wall area owing to remodeling from smoking or other pathologies. So with that, I'll end. I think there's questions. I should give some acknowledgements to the students who do all the work and make it fun to come to the lab every day. Shown here is Paula Dominelli. I mentioned he's at Waterloo. Yannick Mogat, who's now at Winnipeg, and Carly Peters, who defends in a couple weeks, and that's her data that I showed most recently. So thanks for your attention, and if there's time for questions, happy to do so.
Bill, thank you very much. That's great. Really cool. I really like that. Folks, let's take some questions for Bill. We have some time, so lots of questions coming to my mind for sure. Let's go through the, if you don't mind, the Q&A type question asking mode. I'll read the questions for Bill, and we can do it that way. Okay. All right. We'll start with Heather. Great talk. Thank you very much. A few questions. Does the magnetic coil also affect the vagus nerve? That's part one. And since women have a greater work of breathing, yet more fatigue-resistant muscles, is there a difference in blood flow? Let's start with that. She's got a few of them here, but anyway. So let's start with, does the magnetic coil affect the vagus nerve?
It doesn't seem to, no. I haven't made those measures, of course, but others have, and I don't think that it does. Your question about differences in blood flow are questions that we're currently pursuing. So I'd like to know that. Invite me back in a year or two, COVID depending, and then I'll show you that data. But that's exactly the way that we're thinking.
I see. So that relates to the fatigue. Is that the fatigue that you showed, the diaphragmatic fatigue and the type of exercise? What's the cause of that fatigue? Is that a blood flow issue, or is that something else in the situation you were actually measuring fatigue there?
Yeah, I do think it's related to a blood flow issue, and there also is some suggestion that what the blood is doing with respect to pH makes a difference. So, for example, if you replicate an entire bout of exercise breathing, but with no exercise, you don't see that level of fatigue.
Mm-hmm. I see. Okay.
So there's something unique about exercise, and that's one of Mark Babcock's papers from the 90s that's part of their rationale for explaining that.
Mm-hmm. Okay. Last question from Heather is, with the ventilator and reduced pressure changes across the lung, what do you think might be happening to venous return? Do you have any stroke volume or heart rate data on that, or?
Yeah. there is a bit of a reduction in stroke volume from one study. That's from Craig Harm's work, where they had swan gans placed in them, and they showed that a slight reduction in stroke volume for sure.
Mhm.
We didn't see any reduction or change in heart rate. We haven't gone to that length of putting swan gans catheters into people to measure that.
Mhm. Yeah. That sex difference in work of breathing was fairly striking. I guess that, with the emphasis on really focusing research on sex differences these days, that looks like a real, I don't know, somewhere to go with some research questions. No, what do you think?
Yeah, we're pursuing that. I can talk about that if you want. Would you?
Sure. If you want to say something about it, that'd be great.
Sure. So two things we've done. So I showed you that OCT, optical coherence tomography data. We did this study a few years ago now, where we took men and women who were matched for lung size, right? And so they have the same size lungs, and we did a high resolution CT scan, yet the airways are still smaller in the female. Meaning that the constituent components of the pulmonary system don't necessarily grow in tandem. And so if you think of the airways being slightly smaller, doesn't need to be a lot, the resistance to flow is significantly higher.
Right.
As such, the work of breathing is higher. And so we've shown that in a number of studies now. And other people have confirmed that, other labs, which makes me happy. But what's phenomenal to me is that we've done these other experiments where we've isolated the work of breathing to just the diaphragm. And we have men and women perform the same absolute level of work. The vascular response is blunted. It's attenuated in the female.
I see. Okay.
And so we're working our way through kind of the predictable laundry list of why that might be. So we're trying to tackle that right now.
Right. Good idea. Chris Perry is asking, is it stressful to return to normal ventilation after PAV? If so, can emotional stress affect the MSNA burst frequency?
Mm-hmm. Mm-hmm. Is it stressful? So if you're exercising at 90% of maximum and you're on the PAV and they turn it off, you are fully aware of that change. Is it stressful? There is a higher level of dyspnea, so that's possible. The counter argument to that is when we did this at the lower levels of exercise at 40%, it's certainly not a stressful or overly detectable event. So I don't think that explains it, at least at the lower level, but your point is taken about what's happening at high end exercise. In our case, it was 80%. So that's a fair comment. But I don't think it explains what we're seeing at the lower levels of exercise. So my guess is that's not the full explanation.
Okay. Catherine is asking, does the work or cost of O2 cost of breathing change with age? Does it increase in older populations, I guess?
The mechanical work sure does. As you age, you're kind of hit with the double whammy that the lung tends to become slightly more floppy and the chest wall tends to become more stiff. As such, you've changed the compliance of the system. So to generate a given volume costs more from a mechanical perspective. The O2 cost side of that story has not been addressed, and I have a doctoral student who's currently working on that.
Yeah. So when you were doing that O2 cost measurement for the I don't know, the respiratory muscles, it struck me that how do you keep those people from becoming hypocapnic when they're breathing, hyperventilating like that, just sitting still without any, normal? Don't they drop CO2 levels and stuff like that when you're trying to match those pressure volume loops? No.
100% they do, and that's my error. I should have mentioned that. So in that apparatus that I showed, there are 3 bags that we fill those bags with the composition of gas that's required to replicate exercise. So we monitor it in tidal CO2, and ensured that it was where it should be with exercise.
Okay. Yeah. You got that.
That's a great question, because otherwise they'd fall over.
Yeah. I thought about that when you, yeah.
Thank you for reminding me of that. Appreciate it.
No. Arthur Chang is asking, any evidence for sodium bicarbonate ingestion helping to reduce respiratory muscle fatigue and reduce 3 and 4 afferent activation? Any effect of that?
Not that I'm aware of. No.
Yeah, I don't know if anybody's done that kind of work, right? Not on respiratory muscles, maybe on looking at skeletal muscle fatigue, but
Yeah.
Peripheral muscle fatigue, but not respiratory.
You'd want to know that it got into the muscle.
Yeah, I don't know if the bicarbonate may be supposed to act outside in
I see.
providing a bicarbonate pool there for buffering of hydrogen ion.
I see.
Yeah. Anyway, it probably hasn't been done. Yeah. Angelo Belcastro says, nice presentation. Is there any influence of increased body temperature with exercise on respiratory muscle responses like blood flow, airflow, etc.? Is there a need to index to body or muscle temperature?
I don't know the answer to that, but it's a good question. I don't know that anyone's done that. Certainly, coming at it from a different point of view, with an increase in core temperature, there is an increase in ventilation. But that's not really answering your question. So I don't know, Angela. Sorry.
Yeah, that's all right. So you mentioned with age, the lung compliance is, I guess, increases, right? You have a floppy lung, but you have a stiff chest wall. Is that a typical finding with age?
Yep.
Okay. What's the cellular basis for that? As I get older, I'm worried about my floppy lung here. What's going on?
Yeah, I guess I couldn't answer that in any sort of intelligent manner, but the other people can. It certainly does happen. There tends to be a loss or more of an elastic property to the lung parenchyma. It just becomes, there is some destruction or mild destruction of alveoli, which will also change things. But the cellular basis of that, I wouldn't be able to speak with any authority.
Right. Sounds like a loss of elasticity, though, isn't it? Sounds like
yes. That's what's happening. But more than that, you need to talk to someone brighter than me.
Oh, so in this, two things come to mind. A lot of ventilator talk. People put on ventilators, coronavirus, etc.
Yep.
My friend Powers down in Florida, he would talk about artificial ventilation and doing it experimentally and seeing tremendous atrophy of respiratory muscles with pretty short-term artificial ventilation. Put an animal on ventilation, there's atrophy, there's all kinds of protein degradation.
Oh yeah.
Is that what you think is going on in humans in a coronavirus sort of ventilation situation? And the longer, of course, it goes, the more atrophy and the weaker the respiratory muscles, and then harder to recover.
Yes. I'm not an ICU doc, but one of my former students was, and I was talking to him earlier this week. He works at Vancouver General in the ICU, and I mean, they're really trying to keep people off of these ventilators. It's not a great place to be. I mean, if you're there, there's problems, and keeping them off of that is pretty important. So there's atrophy, but there's also injury sometimes if the pressure is not delivered appropriately. I should mention that scenario is very different than what we're using. So we're using a proportional assist ventilator, which is triggered in part by the pressure generated by the subject. So you start to generate a negative pressure and our device breathes for you, and is remarkably easy to just pull it out and you're done. It's a very different scenario altogether. But with respect to ICU patients, I think what you've described is correct.
Yeah. You have a remarkable system of invasive techniques and great ways of measuring pressures and force. And do you see yourself ever, going to the clinical side a little bit and investigating post coronavirus patients and seeing how they rehabilitate, or when it's safe to bring patients in? Is there any, I would imagine CIHR would find this appealing, to see how exercise can rehabilitate people that have been have been unfortunate enough to have COVID, and see if exercise can help rehabilitate. And I wondered if some of your techniques, that you obviously have great skills there to study this, is this something that a direction you might go in the future, do you think, or what do you think?
It's like you've been reading my lab book. Yeah.
Sorry, no, I haven't. We're all immersed in this COVID thing, so
we have some plans for that. We, in fact, with my former student who's an ICU doc, we've been down at the ICU doing just some general observational type things, and it's remarkable. They have people who are. We went down and observed one guy who was on a ventilator because he'd had a lung transplant, and they wheel a cycloergometer up to him, and they have the passive as well as active cycling, double lung transplant, trach, ventilated, and then it's remarkable. They're getting these people to do exercise. But I'm not convinced, based on what I've seen and people I've talked to, that follows even the foundational things you would learn in kinesiology 101, right? Like, so what's the dose? How often should you be doing this? And then there are also some other sociological bits that go with it. The people that tend to get more attention from the physio crowd are the people that have family surrounding them. And so who gets treated, who doesn't, and why? Those are really interesting questions. But yes, we've been thinking about those things. But with respect to our ventilator, the piece that we're not there yet. We still have a number of basic science questions to answer, but I'd really like to do a rehab program in someone who has a weak link in O2 transport, whether it be a cardiac patient, probably right heart failure, or maybe the person with COPD. Could they come to the lab, perform a training bout at, let's say, 45 minutes on a cycloergometer with my device breathing for them? Now they can incur a greater peripheral change than they otherwise would, because they're limited by either bad lungs or bad heart. We're not there yet, but that's kind of the way we're thinking.
Mm-hmm. Yeah, excellent. Arthur Cheng's asking, what is the optimal training stimulus to maximize fatigue resistance in respiratory muscles? Would it involve hip training? Would it involve exercise at some critical power? Does anybody know that?
So I could speak to that in two ways. Cross-sectionally, if you have a group of unfit people and a group of fit people, and you exercise them at their relative 85% or whatever, both of their diaphragms will fatigue. Mm-hmm. Suggesting that, quote, aerobic fitness, whether it's what training regime you pick, I don't know, doesn't seem to confer much of a benefit. One thing that may be related to that, and we've played around with this and others have as well, is specific training of the respiratory musculature. And at least in our hands, we mixed results trying to look at the performance side of this, because those are hard studies to do well. But looking at the blood pressure response, we certainly attenuate it, meaning that we think you've altered the milieu of the muscle such that the reflexive effects are blunted when you train that muscle specifically. So I'm not sure that is it. I think you said Arthur's question, but that's what I know. And I could send him papers if he wants. He could give my email if you would like. That's fine.
Yeah. How do you do respiratory muscle training anyway? How does that work? Independent of doing whole body exercise, because I would imagine that would be a therapy. And again, I go back to the current pandemic that we're in and people having respiratory problems. Is respiratory therapy and respiratory muscle training going to be a suddenly burgeoning area of work, or what's going to happen there?
Yeah, well, there's a whole body of literature on it, and they certainly apply it to patients with obstructive lung disease.
Right.
And that seems to be pretty efficacious in terms of reducing respiratory sensation, improving to some degree their exercise tolerance. Some suggestion that that's true in heart failure. But with respect to COVID, I don't know that they're necessarily running into problems because of respiratory muscle insufficiency. I gather it's more of a gas exchange issue. So it might be a different target. The muscles would be important once you have adequate gas exchange and they're stable that way. Then you, right, trying to recoup them from having been on a ventilator maybe would be the way to think of that.
Yeah. One more question here that I can see. Does breathing rate, either controlled or spontaneous, have any consequences for blood flow to exercising muscle? And I presume that is referring to peripheral musculature, not the respiratory muscle. So if you're breathing fast, does that compromise blood flow to limb muscles? And when you were doing your experiments, do your participants ventilate at a standardized rate?
So in our studies, they do the control condition. And then if they're using a ventilator, we're watching it on screen. Breathe faster, breathe slower, because breathing is a behavioral task. And if this machine's clicking and making noise, some people breathe slower. So you really have to be on top of them. So we did carefully control that. So that's a good question. Does breathing frequency affect, like, depends what you mean by blood flow. Does it affect bulk blood flow? I would think probably not, that I know of. But what it does affect, not so much frequency, but the depth of breathing. There are sympathetic activity is different across a breath cycle. So with lung inflation, there's an inhibition, whereas with lung deflation, there's an augmentation of sympathetic activity. So there's a within breath oscillation of vasomotor outflow. I don't know that that would affect bulk blood flow to any degree.
Right. Okay. Okay, I've got two more questions popping up suddenly before we let you go. Thanks, very nice lecture. How about hypoxia training? Mohammed is asking, do you think it could be an effective strategy for strengthening respiratory muscles, hypoxia training?
Probably not. If the idea there would be that you're ventilating more, you could believe that. But what argues against that is those cross-sectional data that I mentioned. People that chronically breathe with exercise don't seem to be protected in any real way or form from fatigue, at least of the diaphragm. So no, I don't think that that's really going to alter the respiratory musculature in any sort of appreciable way.
Okay. Here's a question more on career progression. Bill, Tanya's asking, I remember reading your early work on cardiovascular drift in rock climbing and applying the same logic in my master's on snowmobiling. From a student's perspective, I find it interesting how careers in research evolve. So how have your research interests evolved over your career to this point?
Okay, well, that's interesting. I mean, if you want the real answer, when I was an undergraduate, and I won't pick on anyone's area, but it was almost more important for me to find out what I didn't like, and then to find out what I did like. And I gravitated towards breathing. Pressures and volumes made sense to me. It was a system that was highly regulated. It had some aspect of engineering, which appealed to me. And you could study it in a human, which was also of appeal to me. And the paper that you're mentioning, the rock climbing paper, that was, if you're speaking of career trajectory, that's kind of an interesting thing, because I do a bit of rock climbing, but I had an undergraduate student who wouldn't take no for an answer and wanted to do this project. And that paper was a function of an undergraduate thesis project. And so I guess I've been tried to be open to student ideas, provided they're at least half baked, and go with it, provided it fits within the general idea of the lab. So that's been a lot of fun, actually, occasionally doing these somewhat oddball projects, but it was a lot of fun.
Yeah, great. Very good answer. Well, Bill, you've been excellent, and thank you for answering all those questions. Folks, I think we better give Bill a break. We've all asked him lots of questions, and I want to thank Bill. Just hang on with me for a minute.
Sure.
When I finish
Thanks
this up.
everyone for the questions. Appreciate it.
Yeah.
Hopefully to see you sometime soon on the other side of this.
Yes, yes. So thank you very much. Thank you very much, Bill, and a great presentation. Folks, that's the end of our webinar today. I thank you all for coming, and we'll see you in a few weeks for the next seminar. Thanks a lot. Bill, stay with me.
Sure.